Hello, this is Lee Schilling, your OBGYN, back for a session on contraception number 3. And this time we'll be talking about implants, injectables, patches, rings, and even IUDs. Sexually active women who never use any method and who never have an abortion would have, believe it or not, an average of 18 births during their reproductive lifetime. Well, this is a picture of implants. When they first came out back in the 70s, you needed 6 of them, and they got put in the upper inner arm. But they were really difficult to remove, all 6. Otherwise, there were no issues with implants. Just taking them out was a big problem. But now technology is so good that it just keeps doing better and better. Now we only have one, and it's much easier to remove. Actually, Implanon and Nexplanon are pretty much the same thing. They're bioequivalent. And the implant consists of a small rod of semi-rigid plastic, and it contains 68 milligrams of etonogestrel. And it's slowly released over 3 years, so they last for 3 years. And the pregnancy rate is 5 per 10,000. The pregnancy rate is 5 per 10,000 women per year for 3 years. That's excellent. This is the most effective thing that we have currently. It's called a LARC, which is a long-acting reversible contraceptive. There are few contraindications: pregnancy and breast cancer, unscheduled uterine bleeding is the most common side effect and reason for discontinuation. Surprise bleeding is just not put up with. Now, I've never had a period, so I'm not sure, but I think if I had something similar, I wouldn't want to put up with it. Still, depends on how long it's going to continue, and you don't always know, but you can find out. So, for healthy non pregnant women, there is no physical or lab test you need before putting it in, and it can be inserted any time unless you're already pregnant, and it can be inserted any time unless you're already pregnant or have current breast cancer. Well, if you have it put in, do you need a backup? Well, if your period was greater than 5 days ago, then you do need backup. And what you can do is just continue using what you have been, or not have sex, or decide on something else that you could get and use. If you want to continue using this, it's okay to insert a new rod through the same incision used to remove the old rod. Well, let's see what we're talking about here. And certainly, if you find you need any numbing medicine while they're doing all of these things, just tell them. nobody else can tell what you're feeling except you. But if you don't tell anybody, they're not going to know. And I mean, it's very easy to numb this so it's not at all uncomfortable. So how do you put them in? And this shows you. And that's a really nice inserter. It's all in one, so to speak. And then uh, after these have been in for 3 years, uh, you can replace it with a new one and use the same opening that you had to put this in and take it out. Okay, so that's about it for the implants. Now we'll go on and talk about injectables, patches, and rings. And they're all pictured here, starting with the injectable at the top left, patch at the top right, and at the bottom is the ring. Well, the injectable is something called Depo-Provera, and it lasts for 3 months, and you need to get a new injection every 3 months. Globally, the Depo-Provera is the only one in the U.S., but globally, two other injectables, both containing an estrogen plus a different progestin, are available. So if you go out of the country and you need Depo-Provera, if they don't have it wherever you are, they have two other things you could use. So when injections are administered on time, they are very, very effective. Side effects include some change in bleeding patterns after a year, no bleeding, or infrequent or irregular bleeding might be your pattern. Weight gain is seen with most users, 2 to 4 pounds a year, and bone loss has been an issue that's still under discussion. However, I think current thinking is that if this is the only thing that you feel comfortable using, then you could use it for as long as you want. And in some studies, they find that when you check for bone loss, in about 4 years, it's back to normal. Not for everybody, but it's still being studied, and you just things evolve as they do. And when you learn more, you can tell whoever's using something what we know about it. There are two forms. You can inject it into the muscle or into just above the muscle in the subcutaneous tissue. And they think this may become a future form for the patient to self inject. So, are there any risks of combined hormonal methods? Certainly. I mean, there are risks in riding a bicycle. So, but I think it's important to let you know about these things in case you're over 35 and you smoke, or you have some rare condition that causes you to have a heart condition or a stroke. And you need to pay attention to this because there are other things you could use that that would not be a risk. Actually, if you have those things and you get pregnant, that's going to increase your risk for death 10 times. So, women older than 35 who smoke more than 15 cigarettes a day, who have multiple risk factors for heart disease like high cholesterol, high blood pressure, diabetes, history of stroke, heart attack, or clots in her legs, history of migraine, they probably shouldn't take the pill. Shouldn't use combined hormonal methods, that's an estrogen and a progestin, during the first 3 weeks after delivery, because the risk of a deep vein thrombosis is higher in the weeks after childbirth if you have additional risk factors for those clots. You should wait to use combined hormonal methods until after the first 4 to 6 weeks following delivery. So just talk about this uh, and realize that after you have a baby, you got 4 to 6 weeks before you're going to have to get maybe back on your old birth control system, but it's something you need to think about ahead of time. So they also say the risk of deep vein thrombosis, that's blood clots in your legs, also may be slightly higher in women taking pills containing a progestin called drospirenone, and in women using the patch. However, the risk of blood clots is higher during pregnancy and in the weeks after childbirth than when taking those things. Okay, now we'll talk about the patch. And where you can place your patch is shown here with little white marks. And they say never put them on your breasts. Now, why is that? That's because of all the stuff we talked about earlier, where the legal system is really paying a lot of attention to medical conditions, and everybody who makes these medical things is concerned about getting sued. So they tell you whether it's important or not. Just don't put them on your breasts. So the patch is a combined contraceptive, meaning it has a progestin combined with an estrogen. You put it on first day of bleeding. If it's applied after the first day, use additional form of contraception for 7 days. One new patch is applied every week for 3 weeks and then off for 1 week. Again, talking about suits, the patch has had some suits because of blood clots that aren't yet settled. Now we go to the vaginal ring, and you can see it really is a ring unless you squeeze it, and then it changes shape very easily. And that's what you have to do when you go to insert these. And it can go anywhere in the vagina. Doesn't have to particularly be here, because the way these things work is it gets absorbed, the hormones in it get absorbed into the blood and the user's bloodstream, and that's regardless of whether it's up here or in the middle or down here. I think it's probably good any time before you're sexually active to just check and make sure it's inside the vagina. I suppose it could come out without your knowing about it, but I don't have a vagina, so I can't really say for sure. So how do you use it? You fold a ring, insert it in the vagina. It stays there for 21 days. You then remove it and wait 7 days before inserting a new ring. During the week the ring is not used, you'll have withdrawal bleeding. And that's the hormones cause the lining of the uterus to grow, and then when the amount of hormone decreases, it causes withdrawal bleeding. Now, if you don't want any bleeding at all, you can use the ring as a continuous dose form of control. Insert a new ring every 21 days with no ring-free week in between. One Nuva ring has enough hormone to last 5 weeks. You can choose to wear it for 3, 4, or 5 weeks, then take it out for a week, and that'll cause withdrawal bleeding, and then replace it exactly 7 days later. If this is done always on a Sunday, may help to remember. Or Planned Parenthood says you could just leave it in for 5 weeks, change it to a new one every 5 weeks or 4 weeks, and have no bleeding at all. Well, next we're going to talk about IUDs, or intrauterine devices. And what you can see here, there are a bunch of different kinds. And I've had patients who got them put in a different country, and that's what all of these show. And this is the copper T Paragard. And this is the Mirena, which has a hormone in here. And these are the US ones. And well, why are they always in different shapes and stuff? It's because they have been patented, and you can't copy somebody's patent. Well, this is the villain. This is called the Dalcon Shield, and they took them off the market, I think, in the mid to late 70s, and it was promoted as a safer alternative to the pill. Well, this particular one wasn't, and the pill wasn't all that dangerous to begin with. But the reason this became the villain was because it had a multi-filament string, and that means that there are several strings wrapped sort of together, and that enables bacteria to climb up from the tail end of that and get into the uterus, and that would then cause infections. Well, there were more than 300,000 lawsuits filed against the company, and the Shield was taken off the market in June 1974. The company eventually filed for bankruptcy, and the Dalcon Shield caused pelvic infections and gave all IUDs a bad name, despite no evidence any other IUD caused any harm. Nevertheless, insurance rates for all IUDs increased, and that caused some companies to stop making them available for economic reasons, not medical ones. So in 2002, IUDs regained popularity, and they're very popular now, I think. And you can put them in after a delivery, and you can put them in if you have a C-section. Put them in at the end of doing the C-section. Once you get the baby and placenta out, then you can put your IUD in, and there'll be no need for backup contraception. And then one thing I've always suggested to people is check every time before sex to know if you can feel the string and make sure your IUD is still there. I mean, checking once a month, unless that's the frequency of your sexual activity, I think you should check every time before. But you can do, I mean, you decide what's important to you. Suppose you do check and you can't feel the string. then you need to check with your personal doctor and let them know. And if the IUD can't be located, that's going to be an issue. And your personal doctor will tell you what to do about that. So, what about pregnancies and IUDs? Well, one, very few people get pregnant if they already have an IUD unless they were in a very early stage of pregnancy when it was put in. So, removing the IUD improves the pregnancy outcome. If the IUD strings are visible, or the device can be retrieved safely from the cervical canal, then it should be removed. Risks for spontaneous abortion in removing it or preterm delivery and infection can exist if the IUD is left in place. Theoretically, the fetus might be affected by hormonal exposure from levonorgestrel IUD. However, whether this exposure increases the risk for abnormalities isn't known yet. So this will show you what kinds of IUDs exist. This is the Mirena, that's the one with the progestin, and this has copper, and this has the progestin, and this is just copper on the end. So you can look across here and you can find out what hormones, if any, are in it, how long it's going to last, average cost, and that's hard to, that changes from time to time. Failure rates, some things work better than others. And device size, I don't think that would have much meaning unless you knew the size of the previous one and you didn't want to get a larger one. Side effects from insertion, a whole bunch of things on the left here. Just look those over and you get a lot of information. And if you decide to have an IUD and you have a printer, print up this thing and take it with you. Now, emergency contraception, formerly known as morning after and postcoital, can utilize an IUD, but you don't want the hormonal one. You want the Paragard copper IUD. And how much the patient weighs isn't really a consideration. There are other things that can be used for emergency contraception, like pills and things, and their weight is a consideration. But the sooner that this is done and used, the more effective it is. Well, clandestine abortion was happening in the 1940s because it was illegal in this country. Over 1,000 women died in the U.S. each year from complications of illegal abortions. Surveys in the 60s estimated that 200,000 to 1.2 million illegal abortions took place every year. 300 deaths were reported. There are a lot that weren't reported. And each year, tens of thousands were left injured but survived. And that's very true. I was in training at the time this was happening. So, should we be prepared for reversal of Roe v. Wade? Yeah, I think we should. But I think it's primarily the physicians who are going to have to be aware. So, should we be prepared? Probably so. There can be things done that just involve taking some pills. And those pills are called mifepristone or RU486. and the mechanism of action is to block the progesterone receptor and consequently the utilization of progesterone, which leads up to changes in the endometrial or the lining blood supply. And you can use mifepristone or RU486 up to 49 days after the pregnancy starts. It's not really an emergency contraceptive, it's called an abortifacient. And this was a study that was done by Dr. David Grimes and maybe some other people here. And what it shows is that abortions are really not that dangerous done in capable hands. And what they're showing is the deaths per 100,000 is less than 1. And if you look at childbirth, it's 12.9. And very, very few people have an issue being pregnant. But the ones who have an issue with these septic abortion deaths, and that's what people die from if they get a bad infection, and that's the 0.7 or 0.8 per 100,000. And it's the reason that they get so sick and die is because of a delay in recognizing the illness, getting medical help, and beginning treatment. And then we're almost through here. What kind of resources? Well, I think Planned Parenthood is an excellent resource, and the Guttmacher.org is an excellent resource. You can get a book. You have to find out where it's available to order one, maybe. Well, thanks for your attention. That's the end of this third series, and thanks for watching.